All right, good morning. Welcome to Palliative Care and Geriatrics Grand Rounds. I'm B.R. Dobman, the course director, and it's my pleasure this morning to introduce our guest speaker. Dr. Todd Cote is an assistant professor at the University of Kentucky College of Medicine and the program director for the University of Kentucky Fellowship in Hospice and Palliative Medicine. He's the chief medical officer of Blue Gas Care Navigators, a large nationally recognized hospice and palliative care organization. He's a board certified in family medicine and hospice and palliative medicine and holds fellow status in both academies. His career has spanned hospice and palliative medicine practice in 4 states, and he is also a palliative medicine specialist in the Republic of Ireland and New Zealand. Previously, he has served as Chief Medical Officer of the Connecticut Hospice. For those who don't know, that was the first hospice in the United States. Dr. Cote is now in his 28th year of hospice and palliative medicine practice and has worked in the clinical, administrative, and political arena at local, state, and national levels. He is the appointed chairman of the Hospice Medical Director Council for the American Academy of Hospice and Palliative Medicine and has been chairman of the Hospice Medical Director Education Committee and served on many other committees in the Academy. Dr. Cote has also been a member of the Palliative Care Regulatory Advisory Workgroup and the Palliative Care Education Committee for the National Hospice and Palliative Care Organization. He has held academic teaching positions in hospice and palliative medicine at Yale University School of Medicine, the University of Connecticut School of Medicine, and Keck School of Medicine at the University of Southern California. Dr. Cote is the co-editor of the Hospice Medical Director Manual, the definitive resource book for physicians in hospice practice. While practicing in California, Dr. Cote was awarded the California Family Physician of the Year Award in 1995, and in 2011, the Pioneer Award from the state of Kentucky for his contribution to innovation in the delivery of hospice and palliative medicine. Please join me in welcoming Dr. Cote.
Thank you. Does this work pretty good? I don't project quite well, so I will try to do that in this amazing room. Thank you. And thank you for that introduction. I'd also like to thank Dr. Jackson for her invitation, along with the Division of Palliative Care and Geriatric Medicine for this really kind invitation. I want to, speaking of Dr. Jackson, hi Vicki, and friend, wonderful. I'm relaxed now because I see, yeah, thank you, beautiful. I wanted to start with a common, straightforward statement that many of you, if you've been in hospice and palliative medicine, have heard before. And that's that statement, if you have seen or worked in a hospice program, you have seen and worked in one hospice program. There is a unified overlying culture of hospice in hospice programs in the United States. But when you start looking at individual programs or comparing programs, what you start noticing is differences in diversity, in philosophy of care, in quality of care, in services rendered, but sometimes in really unique innovations for the future. So that all said, I want to add to the statement direct and say, if you are working in an academic medical center or seen one, then you've seen one academic medical center. There is an overlying culture in the United States within academic medical centers, but when you start looking at individual academic medical centers, you do see differences in diversity, in quality of care, in services rendered, and even in philosophy of care. But you quite often see, like here at MGH, wonderful innovations for the future. I am closely affiliated with an academic medical center, but I'm currently employed by Bluegrass, as was mentioned. Since hospice is considered an industry, I wanted to disclose that on the disclosure slide. My objectives are, I will just read them as I've been asked, discuss strategies for successful partnerships between hospice and academic medical centers, understand how 2 different healthcare cultures with unique challenges and barriers can create opportunities for better care, and then I hope to end with some examples of successful hospice academic medical center collaborations. So in the next 50 minutes or less, I hope I'm going to try to answer the question, can a hospice program, which is typically a small organization, collaborate with an academic medical center, which is usually a very large organization, to improve care for patients and families, both in the academic medical center, in the hospice, and in the community that they both serve. So I'm going to start with this summary slide. So this is my summary slide. In its simplicity, it overlies a lot of complexity. So what I'm going to try to do is break down some of that complexity to answer the question. And since we're in a historic building, I'd like to start with a historical perspective because I really think it's important, and I wanted to share with you today, it's important to our discussion, particularly with the history of hospice in the United States. Now, most of us, when we think of the history of hospice in the United States, particularly for those in hospice, quite often go back to the early 80s when the transformative Medicare hospice benefit came into play. But I'd like to take you back almost 20 years before that, 15 to 20 years before that. So right now, if you can just imagine waking up this morning and not having emails and texts and internet, and really the only way to communicate was as we're doing now, or a rotary dial phone, or writing a letter. Remember those? I want to share with you 5 letters, actually. They are a compilation in Cecily Saunders' book by David Clark. I think the best book on the history of hospice currently. It was published in 2002. It is simply her letters that she wrote to people throughout the world, including in the United States. Dr. Saunders, and this goes back to 1965. I'm looking at some people, and some of you probably weren't born yet. I was 5 in 1965. As a subnote in the book, and I think it's important to mention here, to thank MGH. In 1963, Cecily Saunders made her first visit to America for 2 weeks on a lecture tour that was funded by the Ella Lyman Cabot Trust, which I think still exists here in Boston today. Ella's husband, who started the trust fund in the 30s or 40s, he was a prominent, if not famous, physician, Dr. Richard Cabot, here at MGH. And I just wanted to mention that out of respect to where we are today. Thank you. During those visits is when Dr. Saunders met a lot of important people. There weren't a lot, actually. I said a lot, but there were a handful of people, including Florence Wall, who was the dean of the nursing school. Florence, for several years, had been trying to improve at Yale Medical Center end-of-life care in the hospital there. So this first letter is from Cecily, thanking Florence for the invitation to come within the year and spend some time at Yale. A few months later, Dr. Colin Murray Parkes, who is actually a British psychiatrist, foundational work in bereavement science, that's why he was here at Harvard, here in Boston, was communicating with Dr. Saunders, telling her maybe she should go and meet Elizabeth Kubler-Ross, who was doing foundational work, of course, in death and dying at Billings Hospital, University of Chicago. The next month, there's a letter of introduction from Cecily Saunders to Elizabeth Kubler-Ross. And then the next month, the Institute, which is kind of a think tank work group, 1 week intensive, was carried out at Yale. And as we say, the rest is history. I, with sentimental nature, have met all 4 of these individuals. 2 of them I've talked specifically about, not only these letters, but about that time period. So I feel really privileged about that. But I really, outside of sentimental presentation, what I really wanted to emphasize from this slide is an important feature that you might have already picked up on. These leaders, these visionaries, including Dr. Saunders back in England, all came from academic medical centers. So my view has always been hospice started in America through academic medical centers. So I just wanted to point that out, number 1. At Connecticut Hospice, I was there in early 2000. I got to know a lot of people, including Florence Wall. They had developed in 1972 these 10 principles of hospice care. They were incorporated in 1974 when hospice was first started with home visits in New Haven. But these 10 principles laid the foundation, by the way, for the Medicare hospice benefit. I won't go through all of them. The first one's very interesting because it was forward thinking about person, patient, and family-centered care, which we hear so much about today, even in academic institutions. I mentioning physician-directed and nurse-coordinated. Jumping down to number 8, I just thought was interesting. Home care and inpatient care are coordinated. Now, I want to point out in 1974, there was no hospice inpatient unit in the United States, including at Yale. So the inpatient care, it was in reference right directly to Yale Medical Center at the time. This is from Florence Wall's commentary. What I do want to share, which I, again, am privileged to have spent a lot of time with Professor Wall in her retirement, a humble, wonderful, beautiful, intelligent person. She shared with me 2 failures she thought that she had when she developed, formally started hospice in the United States at Yale. One was, her vision was to have a hospice under one organization, to start certainly in New Haven and then branch out, and eventually every hospice would be within one organization in the United States. As we know, that hasn't come true. Number 2, and really important to our discussion today, she wanted the hospice to be within the hallways of the medical center. She worked very, very hard to try to get particularly an inpatient unit at Yale Medical Center. The administration was blocking that. They did not want a hospice unit in the medical center. They did give her a small office off campus about 3 miles away. She worked hard then had to backtrack for 4 years because it was 1978 that they opened the first inpatient unit here in the United States in Branford, Kentucky. Branford, Connecticut, of course. Branford was about the 11th or 12th township that she had to go through because no one wanted the hospice unit in their township. These are her words. I reflected last week on those 2 issues or visions that she had. I'm convinced I wouldn't be here today if she was successful on those 2 counts. But that said, I am here, and so we continue our discussion. My last letter to show is from Dr. Saunders to Reverend Dobahall, who, again, I had the pleasure to meet in Connecticut. He was instrumental in working with Florence and a small group of people to start developing this national concept to be able to present to our government, particularly HCFA at that time, the precursor of CMS. And so they were trying to figure out how to write up the proposal to present in Washington, D.C. So this is some of her comment. I'll just read. You surely have a problem in protecting the quality of hospice care in the States, rather different from our own. I think that for both, a careful statement of the basic essentials of any hospice program or team needs to be talked round and illustrated and established in the same kind of way that basic essentials of an intensive care unit are fairly well comprehended and established across many frontiers. Again, 1978. The Medicare hospice benefit was transformative to hospice care in the United States. There are 2 pages of milestones, and I won't go through all of these, and I'm sorry it looks busy. What I really wanted to emphasize is a couple points on this slide. One, HCFA, the precursor of CMS, and the US Congress were extremely favorable to the model. They were excited about it. Number 2, as you can see, there wasn't a lot of take early on when they inaugurated it in 1982. The Government Accountability Office did a study 7 years later, and about a third of the programs that were doing hospice model type care were certified. So what did the government do? How do you think they would incentivize programs? Pay them more. So you can see there were increased reimbursement, 10%, even up to 20% reimbursement. What isn't shown in particularly the first several years of hospice care in America for better or worse, and probably for worse, in my opinion, is regulatory oversight and accountability. So process measurement outcomes really weren't mandated. Matter of fact, it was 6 years, 2008, that there was any changes made to the original documents of rules of participation. We call 2008 kind of Vatican II of hospice as a joke. And again, even 2 years later, 28 years after hospice care had been doing good, I think, throughout America, there was any mandate to measure something. We're in the midst of that now. A lot of small hospices are struggling, but this is a needed. Whether the measurements are of value, we're still trying to work out, but we're in that midst. And then in 2016, first time ever there was any change in payment structure. I referenced the asterisk of our friend Joan Tino, who many of you know. We're indebted to her research in hospice and palliative medicine, and Irene Higginson from the UK. They did an interesting blog in Health Affairs this summer, pointing out the new APMs for palliative care, which we're excited about. We hope, Vicki, anytime now, for perhaps a demonstration this year. But they warned APMs to look at the history of the Medicare benefit as a comparison, and the lack of oversight, the lack of really accountability, I think, more for hospices, and the effect it can have over time is a good exercise to look at. So during this time, there were first-generation hospices. I'm proud to be part of one now, and in the past, 1978, our hospice started in Kentucky very early. Boston area has these first-generation hospices. Charles Van Guten, our friend, now in Ohio, published about these hospices, high-quality research and education expertise. I think they were important to the history, but one may ask, where, with all the hospices now, over 4,000 hospices, where did they go? And I think the answer is, well, they're still here, but there's just a lot of other hospices, as we have seen. And I show you the NHPCO slide. Many of us have seen this exponential growth in patients served, which directly correlated with the number of programs increased over time. You can see I was way back down here. We had a large national party when we had 200,000 patients. We thought that was amazing. There's about 1.6 million patients served currently. It has become more linear, particularly as far as patients served. MedPAC also has, which is the watchdog for CMS, that many of us are familiar with, has published more and more data, biannually sort of thing, on hospice. And this is just one of their tables. As you can see, $2.9 billion paid out from Medicare to hospices, compared to 2015, 15.6 billion. It's of course over 16 billion now. To put that in perspective, Medicare home care payouts every year are about 18 to 19 billion. Medicare nursing home payouts are about 33 billion. So as we talk in hospice industry, we're on the radar now for budgetary, obviously, concerns. But you go down and look at some of the other demographics, particularly the median length of stay, which hasn't changed over the years, which is indicative of, again, mostly acute short-term hospice service care to patients. I'll point to our friend Joan Tino again this summer. I have the reference, I can get that to you. This summer did, again, a Medicare deep dive on fee-for-service Medicare patients that died in this exact time period, 2000 to 2015. And I don't know if any of you saw some of those results, but it was compelling. 32% of those patients, Medicare fee-for-service in 2000, died in the acute care hospital. It's down to now 19%, which would seem appropriately good. But what's interesting is she noted that there was quite an increase in the number of patients that died that had an ICU admission in 30 days or less on hospice service. Or within 30 days, they were in the ICU and then on hospice service. Up to about 29, almost 30% fee-for-service Medicare patients now have had an ICU visit, if that makes sense, before they die, which will be pertinent to some of our discussion. So overall, again, hospice program development, I mentioned the 50s, even 60s, important visionaries, really a small, I'm talking 30 people or less in the United States that really came together and certainly went to Congress eventually, and in the 80s adopted the Medicare hospice benefit. Cancer patients focused for various reasons beyond discussion here, but then we started seeing more cancer and non-cancer patients. Education in hospices, there's more literature on how hospices have helped end-of-life care education in the academic teaching environment, particularly at medical schools and nursing schools, than there is on my discussion today. But particularly in the 90s, there was quite a lot of research going into developing teaching expertise, and again, hospices stepped up to the plate there. 2000s into now, there's a whole gamut of issues that some of them we'll briefly talk about. The proliferation of hospices, still research minimal. There's been some there's been some research as to why, and your expectations are probably what is surmised in those studies. Transition to hospice care is extremely important now, particularly with innovation projects and such, and looking at how to transition, particularly out of the hospital. But as I'll show you also, how to transition patients within a hospital setting or an academic medical center, fellowship programs, quality reporting, I mentioned in payment reform. So Bluegrass, where I am, is one of 9 training centers for palliative care called PCLCs. Some of you might have heard that, the Palliative Care Leadership Centers under the Center to Advance Palliative Care, CAPC, which we're indebted to for their continued work. Many of us are involved with that. So Bluegrass, we've been one of the 9 over the last 14 years. And that privilege is a lot of people coming to us, a lot of different organizations, home care, nursing home, hospices, academic medical centers, large teaching hospitals, hospital systems, come in order to be mentored and trained on how to start, particularly in the hospital setting, palliative care services. Now, and also community-based services we're doing now also. It's a privilege for us to, because we probably learn more than what we're teaching, that sort of thing, but what we also hear and have heard, particularly in the last few years, is this really interest on how to utilize and integrate hospice services in our own communities where we're at. This is coming from hospices, it's coming from academic medical centers, it's coming from large hospitals, it's coming from particularly hospital systems. How can they help us? How can we do better? So this is just a list of some of the things that hospices should be thinking of that they can help academic, particularly in this case, academic medical centers with. What should academic medical centers do with or for hospices? I have lots of ideas, but I leave that to you to think about. I think it's an extremely important question. But why collaborate? Do we have evidence in the scientific literature to support this simple diagram, as I showed at the beginning? Quality, cost, and continuity, I think there is some support for this in some of the literature, but I've listed 7 articles here. I think there's about 10, and that's it. Particularly specific to hospices with academic medical centers. Some of these articles I have used effectively with hospital administration and also helping hospices think about things in different ways. But there is evidence. I just wanted to show that slide. Sorry for the mess at the bottom, but those are the 7 articles. What types of academic medical center hospice collaborations do we see? There's really 4 types. So this is a busy slide, There's really contracts, and these are the standard contracts for general inpatient level care that you might have heard about. That's for acute care or short-term acute care. Academic centers will develop simple contracts. Popular and can be effective if led well are contracts for liaisonship. Either hospices support a liaison. I think it's really great if the academic medical center supports a liaison to work with hospices. They're usually nurse leaders, very effective, and that's one area. The second area, and becoming seemingly more popular, is the inpatient unit, be it from a palliative unit that some academic medical centers do have that contract with hospices to come in for certain beds to swing, as we call it, swing it to the general inpatient level, or actually wanting hospice units within the medical center. So that's the second. The third is coordination of community services. Hospices often forget that they are a community-based palliative care service for end-of-life care patients. So I find myself reminding them that and coordinating with particularly what hospitals need to reach out. As you know, there's this what happens after the hospital discharge that hospitals actually have to worry about or focus on, and I think can contribute to really better care in transitions out. Lastly is the traditional educational involvement, ethics committees, advanced directive programs, and so on and so forth. We ask these three questions when we are now consulting more, helping organizations collaborate for hospice services. This is specifically for hospice. We do it for palliative services also. But these three questions I just wanted to bring forth. And quite often the people that we're talking to are surprised that that's the first question we ask, but we're getting right to the point. And I think it is critical that the first question is about what does the academic medical center need. Hospices that do really good work are really eager to help and want to do work, and we're experts and we want, but really it needs to be about what the academic medical center needs. What can the hospice program do? I talked about differences in diversities, the abilities of hospices. Most hospices are small in the United States versus some of the bigger ones, even like ours, which is fairly large. And then do you understand each other, which is this kind of philosophical question, not always well received, but I think it's really important. So I want to talk about just a few of those, particularly the do you understand each other? Understanding culture, and again, in our experience, in my experience, I've had the privilege to kind of be in both worlds when I walk into a hospital, but also in a hospice. But when we're sitting at the table, the C-suite, as we call it, in large hospital systems, we need to respect, we're small, they're big, it's the David and Goliath issue. But more and more, we're seeing hospitals, particularly hospital administrators, very attentive to what we want to talk about or what they need. So we do talk about finance. They better understand kind of the simplicity of hospice payment scheme versus all the complexity of what their hospital is dealing with from a payment scheme area. Regulation, hospices are complaining, I do think appropriately, to MedPAC and CMS and others about audits and so on and so forth. But again, everyone's in that boat as far as healthcare systems. So we remind hospices about that. When we sit, I have been impressed, it's much improved, but 10 years ago and before, talking to hospital administrators, I was surprised that they actually had no knowledge of what really hospice was. They had a grandmother that went through it, but they didn't really understand the administrative issues of hospice. I made presumptions they would, but I think it's like anything else. It's not always easy to understand. The model of care definition, though, these are all actually defining, and these are all things that we get responses from. Quite often hospital administrators do think it's a place over there. You guys, what street are you on? That sort of thing. But again, we usually talk model of care focus. It's, of course, extremely popular right now with all of the different innovations going on throughout the country. I will mention briefly this topic because I know it's contentious in that debate. And I respect that academic medical centers, particularly in large metropolitan areas, have quite a variety of hospices. In Kentucky, there are 22 hospices. I think there's more than that in Boston area. We're a certificate of need state. That's a whole different ballgame. But so there's a variety of hospices, and always something that comes up is the profit, not-for-profit question or non-profit question. In the 2000s, there were a couple scientifically researched articles placed that are published that talk about the difference. They compared, showing that for-profit had less services, those kinds of things. I think they're still in debate as how they were done, and that was quite a while ago. I will say MedPAC is attentive to this situation. The proliferation of hospices has that I showed, the exponential particularly growth, has predominantly been on for-profit hospices. They are concerned about profit margins, to be quite honest. They've noted this. They are concerned about the prevalence of longer length of stay, higher live discharge rates, higher low acuity nursing home patients seen in for-profit hospices. So that's on the radar and being watched. What to do about it and how to address it. And I speak to the general, not specific for-profit hospice. These are general findings from MedPAC. What MedPAC is concerned with, finally, and CMS, is the small minority of hospices that have really poor quality consistently in process measurements particularly, and minimal service. Matter of fact, less than the required services. So there's 4,000 hospices. There's 200 to 400 hospices that are on the radar all the time. I showed you that Medicare hospice benefit trajectory, and again, lack of oversight and accountability has contributed to this minority of hospices that are ruining the majority of hospices' reputation. I'll put it that way. So that's all I wanted to say on that. I do respect the complexity, but knowing your hospice is really important. Another thing that I challenge hospices with is the concept that the requirements to be Medicare certified are minimum requirements. I am impressed with hospices that focus so much on doing what the government says, which is really important. There are rules and regulations, but they don't see it as a minimum. They stop there. So their maximum care is the minimum requirements. And I don't think Medicare ever envisioned that. They just wanted some kind of control. So thinking outside of the box is really important, particularly in the clinical realm. I'm not talking about marketing and all these things. I'm talking about in the clinical realm. And an example of that is the general inpatient level of care. Just so you know, the minimum requirement for a hospice that one of their patients is in or goes to a hospital, and they're on hospice service still under this level of care, the minimum requirement is for the hospice to at least make some kind of connection, through phone usually, to an acute care provider that's caring for that patient to discuss the plan of care. So many hospices, that's what they do. They just call your nurses and talk, and then they document, talk about the plan. I mean, it can be good discussion and such. So the maximum would be actually to send people to the hospice people to collaborate with the acute care team. And we found this is really critically important in acute care hospitals. There's a lot of research to show, even in academic medical centers, less now, but in the 90s and 2000s, that nurses particularly needed a lot of support and ongoing education on dying patients. And I think the best way to do that certainly is palliative care services, but some hospitals don't have that, so having a hospice go in. So actually sending people. Now, I won't talk about the cost of doing that, but it is sustainable and it is doable. But again, a lot of hospices talk about the minimum. show me the data goes to the point of we used to not have, even 10 years ago, much data, particularly about what's happening in the hospital setting. Jokingly, but I unfortunately thought I was smart 10 years ago, this was one of the first questions I would ask the CEO if I got to sit at a C-suite. How many people die in your hospital each year? They knew we were hospice, so I just thought that they would be acceptable to the question. But what I realized is never ask a top administrator of a hospital something they don't know the answer to. Didn't work very well. So, but again, and I actually found myself or ourselves going to the organ donation liaisons because they knew how many people were dying in the hospital. That was a required federal report. So that was back then. Now it's much changed. And data mining studies have shown us, this is Obermeyer, I'm sure some of you know, I think now at Berkeley, was here, and the team and the other great team. We're indebted to these kinds of studies. They're so simple, but they're real. I know it was quite rigorous to look at a patient, all claims in 2011 of the fee-for-service claims, comparing again, as you see, poor prognosis cancer patients that received hospice and that did not receive hospice, and then the outcomes, as you see over on your left, and then the risk ratio of those two comparison groups, and you can see those that receive hospice. I mean, we need this kind of data because we think that's what's happening, but we need to really show and prove it. Cost at the bottom, it's still very expensive, by the way, compared to other countries, of course, in the last year of life, but at least it's less than the patient, unfortunately, that didn't get hospice or for whatever reason didn't get hospice. But we're indebted to this kind of data mining. We also do data mining on ourselves. There's organizations that will do this for you that are contracted with CMS to do this for people. I'm not showing MGH data for any reason other than to show you what kinds of things we sometimes look at. MGH, by the way, compares well to all the other 55 hospitals, perhaps I think in Massachusetts. But you can see we particularly are focused on discharging, this transition of care, and readmission rates. This is a few years back, particularly in our hospitals we serve, including the Academic Medical Center. We're very attentive to 30-day readmission. So we were able to kind of poll and obviously show if a person goes to a hospice, our hypothesis was that there was typically lower readmission rates. And also what happens to patients over time. And here on the other side, you see 6 months, the patients that die within 6 months of that initial discharge. These don't add up to anything, 100% and all that. I just pulled some of the data just to show you how we present to hospices and how we present to even academic medical centers, some of this data to kind of look through real data of real people. Barriers and challenges, I won't, a busy slide, I apologize. These are the really 4 areas though that we see in collaboration of a hospice, particularly with an academic medical center. Expertise is in reference to trying to raise the bar of expertise in hospices. Hospice throughout America, I mentioned the academic hospices do have experts, not only in the clinical realm, but in the administrative realm also. But we need to raise that bar in order to work better with academic medical centers. The legal regulatory, I'll mention the conditions of participation written for Medicare hospice benefit in 1982 weren't written for hospitals to look at. They were written for mostly home care service. So they don't really connect well with the conditions of participation of acute care hospitals. So that is always a barrier and a challenge. It's surmountable, but just something to mention. What we find mostly, interestingly, in our consultation, in our own program development, is system process problems. These are things that seem like, why can't you figure that out? Bed management, IT, electronic medical records. So we'll spend hours and hours of meetings in collaboration, hospital, hospice, and feel very comfortable and confident and have forgot some steps in the IT of the hospital. And so when you implement, literally start seeing patients, everything falls apart. That's consistently a problem. So that's where you start, I guess, is one of my thoughts as far as looking at barriers and challenges. Root cause analysis. Briefly mentioning, did anyone see this article in the New York Times about 3 months ago? This it was titled, which I think is not correct, in my opinion, When the Hospice Care System Fails. It was written well and emotionally by a critical care physician at Brigham and Women's Hospital. Why it was published in the New York Times, I stay away from that geopolitical reason or whatever, but and it was your unfortunate typical scenario of a 90-year-old in the ICU, cared for by the author, that was terminal, decided to go home with children, was discharged the next day, seen by the hospice very appropriately, everything kind of tucked in, a lot going on that discharge day. Everyone was exhausted. So the hospice was going to come back the next morning to complete everything. And you probably know what I'm going to say, but that night the patient had an acute respiratory distress and actually was actively dying. Wasn't doing that when the hospice was there, just acute. Son panicked, called 911. According to the story, the son was told to do CPR, did CPR, of course broke ribs and that sort of thing. Patient transported to the ED. ED doctor at Brigham and Women's calls the doctor who was in-house. Of course, her first thinking was family changed their mind, came back. But when she went down there, saw this actively dying patient intubated that didn't want all that. And I think the story probably carried out that they extubated in the ED. So that was the family experience. So it was an apology to the family. Our last statement, we're the ones who must do better. I don't think hospice failed. I think the whole system failed, is my point to the title. It's easy to kind of pick on or pass it off. I mention this because hospices and academic medical centers and hospitals have done root cause analysis on this exact thing that happens all too often. There are 10 things that happen along the path, all the way from the admission to the hospital, all the way to the home, that we all can do better to make sure don't happen. So I think always a root cause analysis on this kind of process. And it goes to the point of really important collaborations. We need each other to make sure that this kind of transition doesn't happen. How much time do I have? Am I all right? Okay. Thank you. So what I wanted to end my time with is just talking about some successful academic medical center hospice program collaborations. And Vicki knows that the Academy is trying to do some more outreach to fellowship programs, to those of us that have them, guidebooks on finance, on starting a program, and we have one coming out, hopefully, late spring, on integration and alignment of hospice curriculum. And I mention this because part of our guidebook development has been interviewing 8 different programs throughout the country, very different academic medical center programs. But we were all delighted to hear of the kind of unique collaboration that was going on between the hospice and the academic medical center. At the educational level, and particularly at the, again, transitions to care, developing pathways together, all kinds of things that I'd love to share, but it's somewhat proprietary, but it will be coming out. But the hospice management service I wanted to mention is what I've already been alluding to, that from our personal clinical experience, we have seen an uprise in desire for hospital systems particularly to try to integrate, that are spread out in communities, try to integrate hospice services, both in the hospital and again, transition out. And then I wanted to talk, of course, near to my heart is the University of Kentucky Healthcare, Hospice and Palliative Care Services. So this is just a historical slide, and you know, I've never like lectures where someone's up there telling how great their program is. And I'm not presenting this to show MGH how they should do things or any other academic medical center. But it's been really a wonderful journey way back in the 80s when our hospice was the educator in the public health school, School of Social Work, School of Nursing, and medical school for end-of-life care curriculum. So we had that kind of really foundation of work done very well. In 2007, when I came, UK had palliative advisory board, a group of physicians particularly, that really were eager to get palliative care services. They did not have them. As a matter of fact, they were the one of only about 5 in our country, so they were kind of the last to have. They had dabbled with different things, including our hospice services. So we started an adult and pediatric palliative consult service at that time, which really got those of us involved integrated into the hospital. At the same time, and so a year later, we developed our fellowship program, ACGME accredited, and that's going on still today. Interestingly, we were asked by the academic medical center, particularly the department chairs and such, that they wanted hospice services also. They love the palliative, but palliative needs to move. I mean, they were telling us this, which is we need to move upstream, and then the end-of-life care patients, why can't the hospice just do something, and why can't we do that? Mortality rates were an issue in Kentucky, very high mortality rates against other academic medical centers. They were in the bottom, actually 3 to the bottom in mortality rate, meaning high mortality rate, so they were very interested in that. So we developed with them, per their ask, a in-hospital hospice service, which is, again, a swing bed service for GIP, but dedicated team of people to have. That's opened even more doors. So now actually we have very black and white. Do they need palliative? Do they need hospice? We've worked through a lot of, I'll show you a little bit of that. We work with the palliative team. We were the palliative team. Fortunately, the division, we helped them start the division of palliative care and supportive services under the Department of Internal Medicine. And that means we can bring in other experts. So we have wonderful people there now doing that good work. But innovations, as you see way up here, is really very interesting. Transitional care is something we did a Medicare demonstration project with. This is a nurse coach discharge home program where we see the people discharged of high risk in the hospital and then follow them. These are nurse coaches, basically. I medical direct that program. We see 3,500 patients a year. It's a pretty robust program. For now 6 years we've been doing that. You can see cardiac bundle we're involved with at UK, NAS, and low birth weight baby transitions. I wanted to mention, because we are doing about 10 to 12 babies and their families a month in transition with support in the home. That's gained us trust in the NICU, so much so that the palliative team and the leadership in the Children's Hospital now wants a NICU hospice service for expected death babies. Sadly, it's a terrible thing to have to talk about. The palliative team is burdened. They're small. They lack support. We're trying to get more financial support. But the reality is they would love us to come in and do what we do with adults in the NICU. As a matter of fact, the mantra at UK has always been, whatever the kids get, the adults get, whatever the adults get, the kids get, because they're kind of on the same campus, very integrated on the same campus. So I just wanted to mention that. And then we have a hospice unit now, which for the last year now, which built out of our virtual team. We actually have a hospice unit and a virtual team collaborating with all the departments, including the MICU, which I'll talk about, and the palliative team. So best practices, I just wanted, it took a lot of organization time on both sides, dedicated. And I'm talking 30 to 60 people in committee meetings, everything from janitorial to financial at the same meeting, talking about these kinds of innovations that we wanted to do. The hospice team, I won't spend a lot of time with. So these are dedicated people. They get up and go to the hospital. They're employees of the hospice, but they're throughout the team. And the unique character of our virtual hospice service is people like myself and my colleagues, physicians, are the attending. So the hospice medical directors are the attending for these patients. I initially didn't want that, but the department chairs wanted it. They wanted to pass off. I was concerned that, well, we want the experience in a teaching hospital of the blue surgery team to be able to continue to experience the unfortunate nature of end-of-life care. But that's worked out very well and been very accepted. And so that's a 24/7 service for us. Service order sets, including consultation orders. We're in there, hospice service, down lowers, palliative service. The benefits to the hospice, we've been preaching this a lot. I think we've become much smarter as far as our own education expertise by doing this. When I first came to Lexington, my internal anarchy that I usually express was, well, our unit and the other little hospital is great. We see about 600 patients a year, but did you know that 1,100 patients a year are dying closer to us, our office, at UK, and none of those patients are getting hospice service. So as an example of being able to penetrate those that we call that penetration rates, we were able to do that. Cost, there is some evidence, as you see at the bottom, at Rush University and I think at Northwestern, have published that hospice integration in the hospital can save money. This came from the finance department at UK. The first year we did this, $1,500 per day per patient. Cost savings, this was in their analytics. I know that financial departments can have different kinds of analytics. This also included the Medicare per diem also that we negotiated with UK to provide, but just to show that. Busy dashboard, but we started right away with that. Particularly, they were very interested in expected death, expected over-reserve, that sort of thing. Certainly the different kinds, trying to stimulate neurosurgery. They were the first to respond because they were always sending to palliative, but they would call me and say, should I go palliative or should I go hospice? And so we'd have a discussion. So they learned, just, again, how to get people appropriately, efficiently, quickly in the hospital setting to the right service. So overall outcomes of our particularly virtual service, multiple referrals, improved the expected deaths, and as I mentioned, the cost effectiveness. Overall performance improvement, just to briefly mention, pharmacy. UK has one of the top 5 rated pharmacy schools in the country every year. They have an excellent, and that reflects in their program, but when we started, particularly the palliative service, there were no subcutaneous infusion protocols, that kind of thing, so we really worked with them a lot to develop some of the care protocols, particularly for end-of-life care. And again, we were meeting the needs of the academic medical center. So they asked us, can we cohort beds instead of the virtual, or can you do both? And by the way, we'd like you to do both. So we did. And we have a nice 12-bed unit now, designated, collaboratively, and it's working. These are just flow sheets that you can't see very well. I apologize, but we continue to work on process improvement. I'll refer to the left lower corner where you can see 1, 2, 3, 4, 5 phone numbers. So if you get to this point, you're supposed to call one of these numbers. It was a mess. We learned very quickly, so we've already changed that. It's a one call, one number service for anyone that's making a referral within the hospital setting, both transition out or transition to the unit, or do they need virtual. I wanted to briefly mention this, and this may make you cringe a little bit, but again, the medical intensive care unit leadership and critical care and pulmonary care department chair asked us if we could do this. So this is their pilot project. So we're doing virtual hospice service. It's not necessarily unique. The palliative team has been doing a lot of this. Again, a smaller team and quite burdened by this, so they welcomed us doing this too as a hospice. Now we're in-house, of course, at the unit, so it's easy for us to maneuver in the hospital. But their goal was to improve transitions from the MICU. They had the bed transfer, bed loss day issue, and they had a mortality issue. So those two things, that's why they came to us. Thirdly, they wanted to improve quality of care. We thought that was number one after working with a lot of the fellows and such. Interestingly, how an opioid epidemic can trickle down into an ICU. The physicians, even the faculty at UK, were reluctant to prescribe pre, during, and post-withdrawal medications, as an example. Even to today, we had another case 2 days ago. So, okay, well, you guys come and do it. It's like, no, no, no. We want protocols. We'll help you do it. And again, so objective outcomes, as you can see, are listed, subjective outcomes and satisfaction. So all this is being measured now. We started this 4 months ago. We do this quite frequently. Here is a flow chart of the palliative extubation, and I don't like these kind of charts, but these are laminated on the floor. And 2 weekends ago, I was on call, and the faculty who I had just met, critical care specialist, came up, and she brought this and said, this patient needs this, and I think they need. So it's pretty impressive. It's not perfect, and we're still tweaking it. But we're doing most of the palliative extubations. In this one unit, there are 7 others. Of course, guess what? Last week, the CEO wants us to do this in all the others. We had to say no, so we're not doing that. We're not excited about this. We're just privileged to be a part of it. I think we can help. And our intent is really to help, particularly the fellows in training, learn how a process, it's not about just the physical nature of the extubation, it's the pre-discussions and the post-discussions and the bereavement counseling and the anticipatory grief and all those kinds of things which we're able to talk. We are doing this on LVAD withdrawal also, which you would think would be similar in context for the fellows to understand, but they just kind of turn off machines, and we've had a rocky road on that, but we're doing better now with an LVAD withdrawal protocol for those patients. So what have we learned to end? I think my last 2 slides. I mentioned the system process collaboration is really important. I think most of you heard about quadruple aim. The fourth is self-care and helping, and I think a palliative team does that extremely well. An added layer can be hospice integration. We've seen that with our services that I think we are helping. I'm just reluctant. We haven't published enough on it. We concede to being so busy, but everyone says that. I mean, I do think we need to publish more research. We will be publishing the MICU extubation program and some others. The education-wise, this is really critically important for, I think, academic medical centers, for palliative care programs. I do think some hospices can help with expertise, but I think hospices really need a lot of input. A couple academic medical centers have developed centers of end-of-life care excellence, and hospices and others in the community will come to that center to improve quality. Select A players. I mentioned, I'll say this candidly because it quite often gets right down to it. If you have 22 choices, who are you going to go with? We'll go with the, quote, A players, those that have quality research and education expertise. I think that's okay. Now, some states mandate hospitals, transition of care. You have to have a list, or, there's different kinds, each state, so know what your state mandates as far as working with a particular select group. Most states will allow selection. And then lastly, if you've seen one hospice program under one, you've seen one. So I don't know if I've answered this whole question, is this a good thing? Can it be a good thing in context of where we are today? Going back to Florence Wall, I really wish she was successful because I think it could have been a really good thing back then, but that's not where we're at. So it is financially sustainable, and all these things I've been talking about can be overcome. So I think that's my last slide. Thank you for listening in this unique room. I appreciate your time. Thank you.
Thank you so much, Dr. Cote, for such a relevant talk. I think for the sake of time, I'll hold questions, but you are very welcome to come down to the front, and Dr. Cote is very friendly. Thank you.
Thank you.